Hello, good morning. Can you hear me?
Yes, sir.
Good. Okay, I think we can start. So yeah, good
Okay.
morning once again. Um, this is our first time having pharmacology this semester. Pharmacology is something you'll be doing for just one semester. So after this semester, you'll be done with it. I hope you've all gotten the slide because I shared it with your reps earlier in the week. So by now, I am hopeful that everybody has gotten the slide, and not only gotten the slide that you have read, because reading of the slide and understanding it is very important. Good. Why are you studying pharmacology? Pharmacology is something you should know. Why? Because every day you are dealing with drugs. Anytime you go to your facility, you deal with drugs. The pregnant women that come, not a lot of them, almost all of them are on routine drugs, whether they are folic acid, multivitamins, B complex. They are, some of them are hypertensive, some of them are complaining of back pain. There are so many issues that pregnant women present with that need medication. And then you should be able to know what medication will be safe for the woman and her baby. Your work is two troubles. You have two things to always think about. One, uh, 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 um, how safe is the medication for the pregnant woman? And then two, how safe is the medication for the unborn baby? You always have to consider these things. So, in me explaining in us handling pharmacology this semester, I would introduce you to the concept of pharmacology, help you understand the essence of studying pharmacology, and then help you know the role that pharmacology plays in midwifery practice. So, these are the things I'll be taking you through to help you understand. Every week when we meet for pharmacology, I will present my slide for about 1 hour, 50 minutes. And then we'll use the rest of the 10 minutes left to answer questions. So this is how our weekly meetings are going to go. 1 hour, 15 minutes for presentation for my lecture, and then the other 10 minutes will be for question answering. Good. So the image you're seeing on your screen is the image of your primary client. Your primary client is a pregnant woman. And like I said before, you're supposed to consider both the woman and the unborn child that she's carrying. Both the woman and the unborn child that she's carrying. So in pharmacology, you'll be understanding why you're considering both of them at the same time. So, like I said before, your pregnant woman will be on several medications. She will be on several medications. So, your work is to ensure that the medication she's taking is both safe for her baby and for her herself. There are instances where the prescriber would make an error, but you are the one who will be administering the drug to her. So that means that if the prescriber should make an error, you should be able to detect that error. But most often, because we don't understand pharmacology very well, we are not able to pick up on this error. And then what happens is that the patient will end up taking the medication and will be faced with the consequences of having taken those medications. So your duty is to be able to detect some of these medications error and resolve them before they get back to the patient. Good.
Yeah.
So your pharmacology can be simply defined as the effects that drugs have on the functions of living system. We want to study the effect drugs have on the functions of living system. Every medication has a work it is going to do. So in pharmacology, we are trying to study that work, the work that the drug will be doing in the system. The word pharmacology is derived from two Greek words. One is pharmakon and the other one is logia. Pharmakon meaning drug or poison, and then logia just meaning the study of. We have different branches of pharmacology, but the ones we'll be discussing this semester include the pharmacodynamics, pharmacotherapeutics, and toxicology. When we talk about pharmacodynamics, when somebody takes a medication, in pharmacodynamics, we want to understand what the medication will do to the person. In pharmacodynamics, we want to understand what the medication will be doing to the person, the effects that the medication will have on the body, how the drug will be interacting with the body. That is what we want to know. So pharmacodynamics, we want to understand what the drug will do to the body, what the drug will do to the body. But in pharmacokinetics, we want to understand what the body will do to the drug, what the body will do to the drug. So let's get the difference. Pharmacodynamics, when you take a medication, what will the medication do to the body? In pharmacokinetics, you take a medication, what will the body do to that medication? For example, if you take an antibiotic and the antibiotic is killing, or you take an anti-malaria agent, let's say anti-malarial, and then the anti-malaria agent is killing the malaria parasites in your body. When it comes to pharmacodynamics, we want to understand how the medication is doing that work. When it comes to pharmacodynamics, we want to understand how the medication is doing that work. How is it killing the malaria parasites? But when it comes to pharmacokinetics, we want to understand how would the body handle the medication. For example, when you administer artemether-lumefantrine, if you've realized when the people are urinating or they are sweating, you can smell the medication in their urine and in their sweat, meaning that the body is excreting the medication through the urine and through the sweat. So that is what the body is doing to the medication. That is what the body is doing to the medication. It is excreting the artemether-lumefantrine through the urine and through the sweat. So in pharmacokinetics, we want to understand what the body is doing to the drug, and in pharmacodynamics, we want to understand what the drug is doing to the body. When it comes to pharmacotherapeutics, we want to look at how we are going to be using the medication to treat disease conditions. We want to understand how we are going to be using the medications to treat various disease conditions. So your artemether-lumefantrine, how are you administering it? What dose are you administering? What is the dosage? What is the duration of the treatment? All of that pharmacotherapeutics. Understanding how we use drugs to treat disease conditions. And then for toxicology, it is simply the study of the toxic effect that substances would have on the system. It's a study of the toxic effects that substances would have on the system. So generally, at the end, with your knowledge in pharmacology, it will help you administer medication safely to a patient, because you will now know the medications to avoid in certain patients, certain medications that you should give and when to give it. So it will allow you to administer medications safely to your patients. Apart from that, it will also allow you to monitor the patients who are receiving those medications. Most of these medications we administer come with adverse effects. They come with adverse effects. But if you don't know those adverse effects, you can't monitor. So with your knowledge in pharmacology, you should be able to monitor the patients you have given medications to and monitor them very well. You should also be able to provide medication information to your patients. Most of us, when the patient is leaving the facility, all we tell them is take this medication, one in the morning, one in the evening, full stop. One in the morning, one in the evening, and that is it. But that is not, you haven't done your work very well if that is what you are doing. Because at the end of the day, when the person is leaving the facility, you should be able to have told the person, how often should they be taking the medication? One morning, one evening is not enough. If the medication should be taken every 12 hours, give the person the time to take it. There is a reason why we say every 12 hours. There is a reason why we say every 12 hours. So give the person the time. Apart from that, what food should the person avoid? If there is even one to avoid. Should the medication be taken with or without food? If the patient misses a dose, should they take, and they remember later in the day, should they take the medication at any time and then compensate for the one that they have missed? The medication they are taking, is there any food it doesn't like? What should they do if they encounter adverse effects or side effects? If the side effects are too much, should they continue? So there are so many information you should be giving your patient before they leave, but we mostly don't give it because sometimes the knowledge is not there. So when we are done with our course this semester, you should be able to give medication information to the patient. And then you should also be able to provide the appropriate advice to your patients. What they should do, how they should do it, what in their lives they should be changing. So all of these are some of the things that your knowledge in pharmacology would assist you in accomplishing. Will assist you in accomplishing. But before we go ahead, there are certain definitions we should know. We'll be using them throughout the semester. The first is dose. The dose is the predetermined amount of a drug administered at a particular time to produce a certain biological effect. What this basically means is that a dose is the amount of a drug a patient is taking at a particular point in time. The amount of a drug a patient is taking at a particular point in time. When a patient comes with a prescription, for example, cap amoxicillin, 500 milligram, TID for 7 days. Cap amoxicillin, 500 milligram, TID for 7 days. The dose is the amount of drug the person is taking at a particular point in time. So with this definition, in this example I have given, tell me in the chat, what is the dose this patient will be taking? Type it in the chat. What is the dose that this patient will be taking? Cap amoxicillin, 500 milligram, TID for 7 days. What is the dose? What is the dose? Some of you are saying 500 milligram. Are you sure? Are you sure it is 500 milligram? Are you sure it is 500 milligram? Are you sure it is 500 milligram?
Yes.
Okay. So The dose she will be taking, or that a patient to be taking, is indeed 500 milligram. The person who type 500 milligram TID, you are wrong, go, because you've now gone beyond the dose. So the dose is the amount that the person is taking at every particular point in time. So that means that every 8 hours, the person is taking 500 milligram. So 500 milligram in the morning, 500 milligram in the afternoon, 500 milligram in the evening. Dosage, however, is a bit different. For dosage, we are considering the amount the patient is taking and the rate of the administration. The amount and the rate of the administration. So that means that you are looking at how much is the person taking and how often would the person be taking it. So 500 milligram TID 3 times a day, every 8 hours, that would be the dosage. That would be the dosage. So for dosage, you are considering the amount that the person is being administered and the rate of the administration. For dosage forms, we are looking at the physical manifestations that your medication is coming in. Our medications come in the form of tablets, powders, syrups, solutions, capsules, creams, ointments. All of these are dosage forms. All of these are examples of dosage forms. And dosage forms are made up of two main ingredients. Every dosage form is made up of two main ingredients. One ingredient is what we call the active pharmaceutical ingredient. That is the main drug, the main thing that will be doing a work in the patient's body. The other ingredient is what we call excipients. The other ingredient is what we call excipients. Let me use this to explain it. Your paracetamol, each tablet of paracetamol is how many milligram? Tell me in the chat. Each tablet of paracetamol is how many milligram? Tell me in the chat. This one you should know. You should know. Each tablet of paracetamol is how many milligram? Each tablet. Each tablet is 500 milligram. Each tablet of paracetamol is 500 milligram. Yes. Now, have you ever taken the time to weigh a tablet of paracetamol? If you should weigh that tablet's weight would be about 1.2 grams. That tablet will be weighing at about 1.2 grams. So then you ask yourself, how did 500 milligram turn into 1.2 grams? Because the actual medication inside that 1.2 grams is the 500 milligram para. They have added other things to the 500 milligram to make it up to 1.2. For example, have you ever seen a para blister where the tablet inside is breaking apart? It is chipping. The tablet is now breaking inside the blister, inside the sachet. The tablet is breaking. If you see that, it means the tablet was not made well. If you see the tablet inside the blister breaking apart, it means it was not made well. When we are making tablets, to make sure that the tablets stick together and doesn't break, we add starch to the tablet. So that means that when we measure the 500 milligram para, we also have to add a little starch to that pure paracetamol. Apart from that, we can also add color to a tablet. If you realize it is not all para that is white, there are some foreign types that are not white. They come in other colors, especially the US para. They come with different colors. So we can add color to that paracetamol. We can even add flavoring agents to tablets. so that it makes the tablet smell well. We can add sweetness, agents that will make the tablet taste nice, because para is bitter. If you give me that bitter medicine, I would not take. So you rather give me the one that will taste nice. So when you add all of these other ingredients to the real para and you compress it to make a tablet, the weight would now be hitting the 1.2 grams. So the active pharmaceutical ingredient is the pure para, but you have added other ingredients in there so that the tablet can stand. So all the dosage forms you are seeing, they contain both an active pharmaceutical ingredient and also excipients. So when you are seeing amoxiclav, 1,000 milligram, if you weigh it, it will be more than 1,000 milligram. They are just mentioning the amount of active ingredient inside there. If you see amoxicillin, 500 milligram, if you weigh it, it will be more than 500 milligram. They are just telling you the amount of the active ingredient inside there. If you see nifedipine, 30 milligram, and you weigh the tablet, it is more than 30 milligram. They are just telling you the active pharmaceutical ingredients inside there. So every dosage form contains an active pharmaceutical ingredient in addition to an excipient. Adverse effects. Adverse effects are the undesirable effects that a medication can cause in a patient. You've taken a medication for headache and now your stomach is paining you. That's an adverse effect. So adverse effects are the undesirable effects that someone gets when they've taken a medication. A teratogen. A teratogen is a drug or a substance that can cause the fetus in the womb to not develop well, resulting in deformities. This is a substance that can cause the fetus that is in the womb to not develop properly, hence resulting in deformities. So there are some medications that are teratogenic. There are some medications that are teratogenic. Do you know any medication that is teratogenic? If you do, type it in the chat. Do you know any medication that people avoid during pregnancy that is teratogenic? If you do, type it in the chat. Yes. Tetracycline, doxycycline. We avoid those things in pregnancy because it would affect the development of the baby, leading to deformities. So, yes, that is what a teratogen is. When I ask you what is a teratogen, you should be able to tell me. You should be able to tell me. Good. Now, I've been saying medicine, drug. What exactly do I mean? Sometimes the word medicine and drug are used interchangeably, but they usually don't mean the same thing. A medicine or a drug is a chemical substance which, when administered to a living organism, can produce a biological effect. So basically, what this statement means is that it's a chemical substance. If you administer that substance to a living organism, you would see an effect. You would see a biological effect. So when you take paracetamol, your headache goes away. You take antacid, your stomach pain goes away. You take omeprazole, your stomach pain goes away. So that will make it either a medicine or a drug. But we have slight differences between the two. When I say drug, if you listen carefully, but when I mention the name drug, a part of your brain immediately thinks about illicit drugs like cocaine, heroin, and then the marijuana. When the word drug is mentioned, a part of your brain immediately drifts to that side. That is because nowadays the name drug comes with a negative connotation. It comes with a negative connotation. But medicine, if I say medicine, your mind never goes to cocaine or drug or any other illicit substance. So now drug comes with a negative connotation, whilst medicine comes with a more positive connotation. Apart from that too, drugs, we don't use drugs to treat disease conditions, but we use medicines to treat disease conditions. Let me explain. If somebody takes cocaine, tell me in the chat, would they still be experiencing pain? Would cocaine allow somebody to experience pain? Tell me in the chat. If somebody takes cocaine, would the person be experiencing pain? The answer is no. The person will not experience pain. But is cocaine a painkiller? Do we use cocaine in your facilities as a painkiller? No. We don't use cocaine as a painkiller in our health facilities. Why? Because cocaine is not safe. It is not safe to be used. So a drug can have a biological effect, but it is not used to treat disease conditions because they are not safe. They are not safe. But when it comes to medicines would have a biological effect, but they are safe to be used. So that is why your paracetamol is safe to be used, so it's a medicine. Your tramadol is safe to use, so it is a medicine. Your Petidin is safe to use, so it is a medicine. But cocaine is not safe. So it is a drug, but not a medicine. Before a drug will come to you in your health facility, it has undergone various processes. And during those processes, it can have several names. It can have several names. At least about 2 names there it should have. It should have at least, or it will have at least 2 names. The first name it usually has is the chemical name. The chemical name is a name that is derived from the chemical structure of the medicine or the drug. The chemical name is the scientific name that is obtained from the chemical structure of the drug or the medicine. But that chemical name is usually strange. It's usually very, very, very strange. So it is not easy for people to recollect. It's not easy for people to pronounce. It's not easy for people to manage. So we take that chemical name and we come up with a generic name that is easier to recollect and easier to pronounce. So that generic name is usually obtained from the FDA. So the FDA can come up with a generic name. A generic name, for example, paracetamol. Paracetamol is a generic name. Ibuprofen is a generic name. Nobody owns that name. So it is also non-proprietary. I can sit down and make my para and call it paracetamol. You, Deborah, can sit down and make your own para and you'll still call it paracetamol. Mary and Juliet can sit down, make their paracetamol, and they'll still be calling it paracetamol. Nobody owns that name para. Nobody owns that name para. So the name para is a generic name and it is non-proprietary. It is non-proprietary. Nobody owns it. But we have brand names that only one company is able to use because they own that name. For example, Tylenol, only one company is allowed to make Tylenol. No other company can use that name, Tylenol. Only one company is allowed to own Zitromax. No other company can make Zitromax. Only one company is allowed to have that name, Augmentin, Amoxiclav, Ciprodenc, Coatem, Panadol, Gibidol. Only one company is allowed to have that name. So no other company can make a drug and give it that name. So we call those names trade name or brand name. Trade name or brand name. But the issue with trade names and brand names is that there are some places you would go and then nobody will know the medicine you're talking about. In Ghana, Entramol is very, very, very popular. We all know Entramol. But if you go to Togo, or if you go to Nigeria, or if you go to Ivory Coast, or if you go to any other country, even within Ghana, there are some people that would not know what Entramol is. But when you mention paracetamol, they would know. They would know. In order to avoid these confusions, we mostly stick to the generic names. In order to avoid these confusions, we mostly stick to the generic names so that when you are mentioning the medication's name, the person who you are talking to will be able to know what you are referring to or the drug that you are referring to. These generic names usually are what we have on the prescriptions. So the prescriptions you'll be seeing in your facilities, most often they write the generic names. But there are some instances where the prescriber would desire a certain brand, then they will indicate that brand. So that means that when the prescription gets to the pharmacy must dispense that exact brand. The pharmacy must dispense that exact brand. But if the pharmacy doesn't have, they would need to call the prescriber, inform the prescriber they don't have it, for the prescriber to tell them whether or not they can give a different brand. So usually, to avoid confusion, we stick to our generic medicine names. Good. If you look at this table, I have provided you with about 5 drugs. Their chemical name, their generic name, and their brand name. Our Imodium, aka loperamide, just look at its chemical name. If you put this chemical name on a prescription, who would understand it? Our paracetamol, ibuprofen, just look at their chemical names. The worst of all is azithromycin. Just look at all of this. Look at all of this. Who will see this chemical name of azithromycin on a prescription and understand what they are trying to say and understand that this is azithromycin? Nobody will understand it. Nobody will understand it. So that is why we don't use the chemical name. These chemical names are meant for people in the lab. Those who are manufacturing the medication, they should keep those names. These are the chemistry people. They should keep it. It's not our business. Our business is the generic name and sometimes the brand name. So these names are weird. So we don't use them on prescriptions. We don't use them to prescribe medications. Like I said, the chemical name is obtained from the chemical structure. So this is the chemical structure of loperamide. This is the chemical structure of ibuprofen. This is the chemical structure of your paracetamol. This is the chemical structure of your amlodipine, and this is the chemical structure of azithromycin. Do you see how weird the structure of azithromycin is? That is why its chemical name too is also weird. That is why its chemical name is also weird. But before a medication would land in your facilities, it would have undergone various processes. It will have undergone various drug development processes. We all know certain herbs that people use to treat disease conditions. What herb do you know that people use to treat disease conditions? What herb? What herb? What herb? And then when you're telling me in the chat, you tell me the disease you know that they have been using it to treat. What herb? Regina. Regina. Hey. Regina, please tell me, what disease have they been using it to treat? Tell me, what disease have they been using it to treat? So yeah, neem tree, bitter leaves. Yeah, neem tree for malaria, even bitter leaves also for malaria. Yes. Tabia. What plant is tabia? Zoom user. What plant is tabia? Yeah, mango leaves. Yes. Cloves for candidiasis. Yes. Apple for Sodium apple leaves. Okay. Bitter leaves for ulcer. A champon. What is the English name for a champon? Josephine. What is the English name for a champon? Scent leaves. Good. Mint leaves for ulcer. Good. Guava leaves for fertility. Wow. Good. So, yeah, we have different leaves or herbs or plants that we use to treat disease conditions. Lemongrass for malaria, yes, lemongrass for malaria. But if you've realized, when the herbalists are selling the medication or they are selling their herbal products that they have used plants to make, they will tell you that that single plant can treat all the disease conditions in this world. It can treat malaria, it can treat hypertension, it can treat diabetes, it can treat infection, it will boost the immune system, it will handle all injuries, it is going to make the heart strong, it's going to handle fertility issues. That single drug. Technically, they are not wrong.
Good morning.
Technically, they are not wrong. Why? Because technically they are not wrong. Why? Because plants contain a lot of chemicals. They contain different types of chemicals. And these different chemicals have different works that they can do. They have different works that they can do. So when they go and they boil the plants, they are removing the chemical from the plant and putting it inside the water. They are extracting all the chemicals from the plant and putting it inside the water so that when you drink the water, you have drunk the chemicals from the plants. And the chemicals in the plants will now enter your system and go and perform all the different works that they can perform. But if you have realized, the orthodox medications, they usually treat a single condition or a limited number of conditions. The orthodox medications, they usually treat a single condition. For example, your nifedipine is only for what? Hypertension. Your paracetamol is for what? headache and fever. So they treat a limited number of conditions. Meanwhile, they are still obtained sometimes from plants. So how come your orthodox medication is handling only a limited number of conditions, while the plant is handling a large or a wide range of conditions? How is that possible? One, the orthodox medication, they usually go and select only one chemical from the plants, and they use that chemical to develop the medication. For example, let's take your, let me use this scenario, your bitter leaves. Bitter leaves can be used to treat different conditions, including malaria. If I want to produce my own anti-malarial drug using bitter leaf, what would I do? I would boil the bitter leaf. No, we don't boil the bitter leaf. We do what to it? They say we wash it. Yes. Or we pusa it. So after pusaing your bitter leaf and all the water, all the chemical enters into the water, I can go to the bitter leaf extract I have gotten and then use whatever chemistry knowledge I have to select the particular chemical that is responsible for the anti-malarial effects. I will go to the bitter leaf, identify the particular chemical responsible for the anti-malarial effects, and then isolate that chemical. When I isolate that chemical, I can now do certain tests on the chemical to come up with my medication. What is the first test I would do? I would do pre-clinical trials. Pre-clinical trials, where I would test the medication first on animals. I would test the medication first on animals. So I can test it on rats, I can test it on mice, I can test it on guinea pigs, I can test it on chicken. And why am I testing it? To check whether indeed that chemical is safe. If I give that chemical to a rat, to a mice, to a chicken, or to a guinea pig, and then they die, the animal dies, it means that that medication is not, or that chemical is not safe. And if that chemical is not safe, it means I should not even bring that chemical close to a human being. I should not even bring that chemical close to a human being at all. So in preclinical trials, you are going to be establishing the safety of that medication, of that chemical. You want to determine whether that chemical is safe or not safe. Is safe or not safe. After determining that it is safe, you can infect the rats with malaria, give the chemical to the rat, and check whether the malaria of the rats will go away. Check whether the malaria of the rats would go away. If the malaria goes away, it means that that chemical is effective against malaria parasites. It is effective against malaria parasites. But if it is not effective, then you know that it is useless even trying it on a human being. You know that it is useless even trying it on a human being. So in the preclinical trials, you want to check two things: whether the chemical is effective against malaria or whatever disease condition you're trying to treat, and whether it is safe for use, whether it is not toxic. If the chemical is toxic in animals, it is likely going to be toxic in human beings. If it is not efficacious in animals, it is likely going to be not efficacious in human beings. So in the preclinical trials, you'll be testing on animal to determine whether or not the medicine is safe and effective. It is safe and effective. If the medicine passes, then you can begin to test in human beings, starting with the phase 1 clinical trial. Starting with the phase 1 clinical. In the phase 1 clinical trial, you will be testing the medicine on healthy individuals. Individuals who don't have malaria, you'll be testing the medication, the chemical on them. So you will gather about 20 to 100 healthy volunteers. You will administer the medication to them, or no, not the medication, the chemical to them, and you will see the effects the chemical would have on their system. You will check the effects the chemical would have on their system. The reason why you're doing this is so that you will see how the medicine or how the chemical would interact with the healthy tissue. What is it going to do to a healthy tissue? If it is going to make or destroy a healthy tissue, if the chemical is going to destroy a healthy tissue, it means you shouldn't even bring that chemical close to somebody who is sick. It means you can't even bring that chemical close to someone who is sick. Because we are assuming that the healthy person should be able to withstand the medication's effects, but the person who is not well would be less likely to withstand the medicine's effects. And we will not be giving the medicine to somebody who is healthy. We'll be giving it to someone who is sick. So in the phase 1, you are testing it on about 20 to 100 healthy individuals. And you are doing this to check whether it is safe to be given to them and how they would react to the medication or the chemical. If they don't react well, if the healthy people don't react well, you are not going to go into phase 3. If the healthy people don't react well, or they produce a very bad adverse effect or side effect, you would not graduate into or you not progress into phase 2. You will not progress into phase 2. So it is only when they do well, that is when you will progress into phase 2. Someone is asking, but by checking on animals, how would you know their headache is gone, even if the animal does not die? We have various tests, animal tests that we pharmacologists do to be able to assess the pain of animals. Aside from pain, we have various tests that mimics human conditions that we use to assess animals. There are assessments for pain, there are assessments for depression, there are assessments for diabetes, there are various behavioral assessments. So we can use. Sorry about that, I got disconnected. So let's continue. Like I was saying, there are various test methods you can use to assess these parameters in rats. So when the chemical passes with healthy people, then you can graduate into phase 2. In the phase 2 clinical trials, you will now be testing it for the first time on people who have the disease condition, like the malaria. So that means that chemical that has passed the phase 1, you are going to test that chemical in patients who have malaria. You will test it in patients who have malaria. In testing it in them, you are trying to find out whether the chemical is effective against that disease condition and whether they are going to experience terrible adverse effects. and whether they will experience any terrible adverse effects. So these are the kind of things you'll be checking in the phase 2. If the chemical does not treat the disease condition, or if it is not safe, you cannot graduate into phase 3. You cannot graduate into phase 3. But when you come to the phase 3, in the phase 3, you see, if you've realized in the phase 1 and phase 2, you are using a maximum of about 100 individuals. You are using about a maximum of 100 individuals. But in phase 3, you would have to recruit a larger number of people. You have to recruit a larger number of people, up to 3,000. And then these 3,000 people you are going to be recruiting are people from different ethnic backgrounds and different races. So that means you have to be recruiting Caucasians, Asians, Africans, Black Americans, Indians, Middle Eastern people. You would have to recruit all of them. Why? Because medications sometimes react differently or behave differently amongst people of different ethnic backgrounds. There are some medications that work perfectly for Black people, but if you give them to whites, they don't work well. There are some medications that work well for whites, but you give them to Black people, it doesn't do well for Black people. So you're doing this to find out all these differences. You're looking at the adverse effects, the dosing, the safety. You're going to be using the phase 3 to identify all of these things. And then if the chemical passes, then the FDA would come. Then the FDA would come and then give you approval to start selling your medication. When your drug or your chemical passes phase 3, FDA would now come in and tell you, oh, we like the chemical you have made. Take this license and start making and selling the medication. So you can now start selling the medication after the FDA has come in when you are done with phase 3. But when you are done with phase 3 and you start selling the medication, your work is not done. You have to undergo phase 4 clinical trials. You have to undergo phase 4 clinical trials. In the phase 4 clinical trials, we call it pharmacovigilance. We call it pharmacovigilance. Pharmacovigilance, what it means is that you are going to be monitoring all the different people who are taking your medication worldwide. You are going to be monitoring all the different people who are going to be taking your medication. Why? Because there are some effects you would experience or you would see in the phase 4 that you did not see in your phase 3. There are some effects you see in your phase 3 that you would not see in your phase 4. Let me give you an example. We've all heard of this drug called Viagra before, right? All heard of Viagra before.
No.
When you have, madam, you have had it, you know the medication. The men usually use it for erectile dysfunction. Men usually use it for erectile dysfunction. When they were making that medication, the company that made that medication did not make it for erectile dysfunction. They made that medication to treat hypertension. They made that medication to treat hypertension. So that means that right from the preclinical trials all the way down to the phase 3, they were using that medication to treat hypertension. So that means they were testing it throughout the preclinical trials to the phase 1, to the phase 2, to the phase 3. We're all testing that medication for hypertension. But after the phase 3, FDA gave them license to start selling the medication. FDA gave them license to start selling the medication. When they started selling the medication, the company now realized that men who are taking the medication were complaining of sustained erections. And not only were they complaining about it, they now realized that even the blood pressure reducing effect of the drug was not so strong. So the drug wasn't reducing the blood pressure the way they thought it would, and then the drug was now causing sustained erections. So usually in this situation, what the company would do is that they would recall the medication. They would recall the medication and then scrap the medication from the system. But then the company now said, instead of us to scrap the medication and then lose all this money, why not we rather change our marketing strategy? Stop marketing the drug for hypertension and now start marketing the drug to treat erectile dysfunction. And that is how they made a switch. So they now switched from hypertension and are now doing erectile dysfunction. So if they did not do their pharmacovigilance in phase 4, if they didn't do pharmacovigilance in phase 4, they would not notice this. So phase 4 clinical trials is for you to do pharmacovigilance to see what your medication is doing to people. Whether people experience very bad effects, whether they are experiencing things that you didn't see previously, and if you are seeing new things, how does it affect the way your drug would work and how you will market your drug? So before a medication will come to you, it would have undergone all of these processes. It is after it has undergone from preclinical trials to phase 3, that is when it will now come to the market under a brand name. This entire process can cost billions of dollars. It can cost billions of dollars and can take about 10 to 20 years before the medicine will come out. It can take about 10 to 20 years before the medicine would come out. Now, when the medicine comes out and it is being sold, it would not be sold for 5 cedis. It would not be sold for 5 cedis. That medication is going to be sold for thousands and thousands of cedis. That is why you see some medications costing 1,000 cedis, some are costing 2,000, some are costing 800. They are very expensive. Why are they expensive? Because they have undergone all these processes, and then the company needs to get its money back. The company needs to make its money back. That is why you can see certain medications being very expensive. And those medications are usually the innovator brands. Zitromax, Zenat, Augmentin, Coatem. They are the innovators of the brand. They have undergone preclinical trials all the way to clinical trials. So for the 10, 20, Rocephin, yes, for 10 to 20 years, only them are allowed to sell that medication. No one else can sell the medication so that they can recoup their investments so that they can recoup their investments. Then Akosia would now come and say, the drug is expensive. We can't afford. Why is it so expensive? So that the company will get their money back. That is why it is expensive. So it is after the 10 to 20 years elapses. After that 10 to 20 years elapses and the company has gotten their profit back, FDA will now come and tell the company, you have sold the medication enough. You've gotten your money back. So now, please release the properties of the drug you used, the chemical you used to make that drug, so that other companies can also make the drug. So when they release the company, when they release the chemical's name and its properties, what will now happen is that India, China, US, no, not US, UK, Ghana would now make their version. And then usually their version will now be cheaper. That is why you can have the generic cephalozyme costing less than 100 cedis. Meanwhile, Zenat is costing about 200 cedis. You can have the generic Rocephin or ceftriaxone costing about 15 to 20 cedis. Meanwhile, Rocephin is costing about 200 cedis. So it is when the company is done that is when everybody else can now come to sell their own brand or their own type. But when all these other companies are coming to make their own drug, they don't undergo clinical trials. They don't need to undergo clinical trials. So that is why their medications are usually cheaper, because they haven't undergone clinical trials. It is only the innovator brand that has undergone the clinical trials. That is why certain prescribers and specialists, they would always recommend the innovator brands, because they know that those ones are what have undergone clinical trials and has proven to work. But the other ones, they haven't undergone clinical trials. So we are assuming that they are working, but we don't know for sure that they are working as well as the other brands. Good. So that is the drug development process. Now we classify medications. Now we classify medications via different. Sorry, there's something wrong with this slide. I'll replace this PowerPoint for you. There's something wrong in it. Okay, so we have different ways of classifying medications. We can classify medications as prescription. We can classify medications as prescription-only medicines. Apart from prescription-only medicines, we also have something we call controlled medicine. So please, in your notes, cancel out pharmacy medicines, cancel them out, and then make it controlled medicines or controlled substances. Cancel out the pharmacy medicines and make it controlled substances. Make it controlled substances. So you can have prescription-only medicines, which are medications that are obtained only based on prescription. You can get them only based on prescription. The controlled medicine, those are, or controlled substances, those are substances that people can easily get addicted to them. People can easily get addicted to them. So we usually keep those ones under lock and key. We usually keep those ones under lock and key. What it means is that if you go to your facilities, There are certain medications that we keep in special drawers or cabinets and we lock them up. What medication do you guys lock up in your facility? Can you tell me? Type it in the chat. What medication have you noticed that your facility locks up in a cabinet or in a drawer so that people don't easily have access to it? Yes, Petidin, morphine, tramadol. Petidin, morphine, tramadol. Yes, those are the medications that people keep in your facilities under lock and key. And it's not everybody that has access to that drawer. Why? Because those type of drugs are easily abused. Those type of drugs are sometimes easily abused. So we control them. So they are controlled substances. They are controlled substances. Apart from the prescription-only medicines and the controlled substances, we also have another class of drug that we call the over-the-counter medicine or the non-prescription drugs or the non-prescription drugs. These over-the-counter medicines or non-prescription drugs, you can walk into any pharmacy and get them without a prescription. So that means that paracetamol is a non-prescription drug because you can get it without a prescription. Diclofenac is non-prescription. Most of your antacids are non-prescription. Your artemether-lumefantrine are non-prescription. Antibiotics are not non-prescription medications. The antibiotics we take, the oral antibiotics, they are prescription medications. So your over-the-counter medications, they are the drugs you can get without prescriptions. And why can you get them without prescriptions? Because they are safe to use, even without having to monitor the patient. They are safe to use, even without having to monitor the patient. So those are some of the classifications of medications. Apart from these classifications, we also have other classifications based on mechanism of action, physiological effects, and the chemical structure. We have other classifications based on mechanism of action, physiological effects, and chemical structure. Let me give this example or this scenario. Bacteria has a cell wall. For those of us that did microbiology at some point, in fact, everybody here has done some form of microbiology, but I'm sure you have thrown away that knowledge. Please bring it back. Bacteria has a cell wall. There are different antibiotics that are able to prevent bacteria from making its cell wall. So those type of antibiotics, we classify them under medications that prevent bacteria from producing cell wall. So that means that we have classified them based on their mechanism of action. We have classified them based on their mechanism of action. So that means that any drug or any antibiotic that is preventing bacteria from making its cell wall will be classified as an inhibitor of bacterial cell wall synthesis. It will be classified as an inhibitor of bacterial cell wall synthesis. So that will be a classification based on mechanism of action. We can also have classification based on physiological effects, where every medicine that is killing bacteria will be called an antibiotic. Any medicine that is killing fungi can be called an antifungal agent. Any medicine that you are using to treat your pain is called a painkiller or an analgesic. So these are classifications based on physiological effects. We are classifying those drugs based on the effects they have on the body. And we also have classification based on chemical structure. So if you have two drugs whose chemical structure is similar, you can classify them together. You can classify them together. Let me show you this example to buttress my point. Let me show you this example to buttress my point. If you look at amoxicillin and penicillin, look at their structure. This is amoxicillin, this is penicillin. If you look closely, you'll see that they are related. Why am I saying this? I'm saying this because they have this portion and this portion being the same. They have these two portions being exactly the same. What has changed is that for amoxicillin, amoxicillin has now come to have only this thing, whilst penicillin has this one. That's the difference between the two. That is the only difference. That is why both of their name is ending in what? Cillin. So amoxicillin, penicillin, ampicillin, cloxacillin, flucloxacillin. All their names are ending in cillin because in terms of their chemical structure, they are similar. Tetracycline, doxycycline, they are similar in structure. That is why their names are ending in what? Cillin. Which other drug do you know whose names are ending in a similar way? Or you don't know any?
Flucloxacillin.
Flucloxacillin, yeah, so it's part of the cillin groups. So all those drugs, the penicillins, amoxicillin, ampicillin, cloxacillin, we classify them as penicillins because penicillin was the first one that came. And then we modify penicillin slightly to give you amoxicillin. So all of these are types of penicillins. So we classify them all together as penicillins.
Penicillin group.
Yes. Your cefuroxime, ceftriaxone, cefixime, all their names are starting with kef. So all medications whose name are starting with kef, they are all cephalosporins. Why are they cephalosporin? Because their structure are similar. So when you see two medications whose name is spelled similar or is sounding similar, it should tell you that they are similar in terms of their chemical structure. Nifedipine, amlodipine, nimodipine, felodipine, all their names are ending in dipine. Why? Because they have similar structures. So that is one of the tricks to medications. When their names are sounding similar, it should tell you that they are likely coming from the same class. They are likely coming from the same class, or that they are having similar structure. I have given you this class of medications based on physiological effects. I would entreat you to go and find out what each of them mean. So this is your small assignment. Will I collect this assignment from you? No. But the day I will come for it in your quiz or in your mid-semester exam or in your end of semester exam, please, you better have it ready for me. So go and find out what all of these things mean, these classes mean. What work do they do? That's the thing. What work do they do? What work do they do in the system? So go and find out these ones. We have different sources of medication. We can get medications from three main sources. The first source you can get medication from is the natural source. We also have the synthetic source, and we have the biosynthetic source or the semi-synthetic source. The biosynthetic source can also be referred to as semi-synthetic source. When it comes to our natural source, it means your drug is coming from nature. The drug or the medicine is coming from nature. So that means plants, animals, microorganisms, minerals, marine. You can get these drugs from these sources, from either plants, animals, microorganisms, etc. So when your drug is coming from these sources, we call that drug a natural source drug. We call that drug a natural source drug. So that will make all our herbal medicines natural source drugs. That will make all our herbal preparations natural source drugs, because the herbal manufacturers, they get those medications purely from herbs. And herbs are plants, they are natural sources. Now, there are instances where you will get a natural drug, and then the natural drug doesn't have properties that you like. The natural drug doesn't have properties that you like. So you'd want to change it. You'd want to do some changes. For example, if you have a natural drug that every 4 hours, the drug is leaving the system. Every 4 hours, the drug has left your system. But you want the drug to stay longer in the system and work in the system for a longer period. That every 4 hours, it doesn't help you, because it means that 6 times in a day, you'll be taking the medicine. And nobody wants to be taking medication 6 times a day. So what would me as a pharmacologist do? I will get that medicine, look at its chemical structure, and then make a slight change in the chemical structure. And when I make that slight change in the chemical structure, it can make the drug stay longer in the system. So that instead of it leaving the system every 4 hours, it is now leaving the system every 12 hours. That means I'll just be taking the medicine twice a day. So when you get a natural drug and you change the chemical structure of that natural drug to create a different drug, that different drug you have created is what we call a biosynthetic or a semi-synthetic drug. That new drug you have created by changing the chemical structure of a natural drug is what we call a biosynthetic or a semi-synthetic drug. So we create biosynthetic drugs or semi-synthetic drugs in order to improve the potency, efficacy, and other parameters of the medicine. So that is what we call a biosynthetic drug. We also have another class of drugs that we call synthetic drugs. These ones are gotten purely from chemical reactions. There is nothing natural about this type of drugs. There's nothing natural about synthetic drugs. They are gotten purely from chemical reactions. I have provided you with a table with examples of drugs, and then the class, and then the source they fall under. Let's look at this. Quinine. Quinine is obtained from a natural source. What is the exact source of quinine? It is gotten from a plant called cinchona. If you boil the back of the cinchona tree, you will get quinine, and quinine is used to treat malaria. Morphine. Morphine is obtained from opium, the fruit of opium. And we use morphine as an analgesic. We use morphine as an analgesic. Your penicillin. Penicillin is gotten from a bacteria called Penicillium nonatum. And penicillin is an antibacterial agent. Even your glycofulvin. Glycofulvin is gotten from a bacteria, but we use it as an antifungal agent. But let's look at our semi-synthetic drug. For your semi-synthetic drug, you will get your natural drug, change the chemical structure of your natural drug to create a semi-synthetic drug. So look at heroin. Heroin is gotten from morphine. Somebody sat down, looked at the structure of morphine, made a little change in the structure of morphine to be able to get heroin. Look at ampicillin. Somebody made a change in the chemical structure of penicillin to be able to give you ampicillin. Your dihydrocodeine. Somebody made a change in the chemical structure of codeine to be able to give you dihydrocodeine. So these are semi-synthetic drugs. They have been made by altering the chemical structure of natural drugs. They have been made by altering the chemical structure of natural drugs. But the drugs that have been made purely from chemical reactions or chemicals, those include aspirin, prednisolone, and then metformin. Aspirin, prednisolone, and metformin. Those are examples of synthetic drugs. This image is an image of the opium fruit from which morphine comes from which we get morphine. Now let's go to dosage forms. We have different types of dosage forms. We have already defined what a dosage form is. Earlier in the presentation, I told you that dosage forms are the physical manifestations that your medications come in. So your tablets, your capsules, your syrup, your solutions, etc., all of those are the type of dosage forms we have. I would not discuss all the dosage forms that have been listed on this slide. I'll discuss a few of them. My job is to do the easy one, and I'll leave the difficult ones for you. So yes, I would handle a few of them, and you will do the rest. I'm going to start with solutions. I will start with solutions. So a solution is a homogeneous mixture. You have mixed a solid and a liquid together, and what you have formed is a homogeneous mixture. That is what you will call a solution. When you mix a solid and a liquid, a solid medication with a liquid, when you mix the two together and you form a homogeneous mixture, that homogeneous mixture is what we call a solution. Your normal saline is made up of sodium chloride, and sodium chloride is a salt. And when you mix sodium chloride with water, you will form normal saline. So when it comes to solutions are a combination of a solid medication that has been dissolved inside a liquid. A solid medication that has been dissolved inside a liquid solvent. So that is a solution. And then for solutions, if you store them, the solid would never come out of the solution. For example, no matter how long you have stored sodium chloride or your normal saline, you would never see the salt coming out of the of the infusion bag. You would never see that happen, because at every point in time, the solid is dissolved inside the liquid. So it will never undergo phase separation upon storage. So those are solutions. I've given normal saline dredge solution. I know you are aware of other types of solutions. Good. Now let's do suspension. Whereas in solutions, you are mixing soluble solid with a liquid. For suspensions, you are mixing an insoluble solid medication in a liquid solvent. For example, if you look at who is this person yellowing? For our suspension, if you look at your magnesium trisilicate, MMT, you can see all the solid particles inside it. Why? Because those solid particles are not soluble. They don't dissolve in the liquid. So it makes that mixture a suspension. So a suspension is a mixture of an insoluble drug in a liquid medium. It's a mixture of an insoluble drug in a liquid medium. And then that insoluble drug would never dissolve. It would never dissolve in the in the liquid medium. Now, if you leave a suspension standing, the solid component of that medication is going to sediment. It will settle down, it will sediment. So, because the actual medication is the insoluble solid, you must always shake to evenly disperse the solid medication before you can take the medication or you can administer the medication. That is why all the suspension, they've written on the body, shake before you drink, because the real medication is the solid that is suspended. So if you go drinking the water alone, you're just wasting your time. So you would have to shake to disperse the solids, which is the main medication, before you administer that medication. Now, if for any reason you are shaking the medicine and then the solid is not dispersing, please don't go and find a wall to be knocking the bottle on that wall. The wall would break, and it means that that medication is compromised. All suspensions should not have difficulty being redispersed. So once you're having difficulty redispersing that medication, there's an issue with that drug. So just discard it. Just discard it and go and get another one. Discard it and go and get another one. Don't go hitting it against the wall and then you squeeze your face and and frown and then you're hitting it. No, please throw it away and go and get another one. When that happens, it really means that there's something wrong with the medicine. Now we have something we call emulsion. Emulsion is made up of two liquids that don't mix together. We usually use oil and water to make emulsion. We usually use oil and water to make emulsion. The mixture between the oil and the water is not 50-50. One is always more than the other one. So because of that, we have two types of emulsions. We have an emulsion where the water is more than the oil. And we also have another emulsion where the oil is more than the water. So oil where the water is more than the oil, we call it an oil in water emulsion. Oil emulsion where the water is more than the oil, we call that emulsion oil in water emulsion. So the oil is small and the water is plenty. Whichever of them is small, we call that the dispersed phase. So the smaller one, we call that a dispersed phase. The larger one, we call it a continuous phase. So in an oil in water emulsion, the oil is the dispersed phase and the water is the continuous phase. But in a water in oil emulsion, meaning that the water is inside the oil, the water is small, so it is the dispersed phase, whilst the oil is plenty. So that oil is now the continuous phase. That oil is now the continuous phase. So emulsions, you are mixing oil and water together. Has any of you administered artemether injection before?
Yes.
Has any of you administered artemether injection? Most of you have.
Yes.
Yes. Most of you have administered artemether injection before. Now, how does the injection feel in your palm? I'm sure it felt oily, right?
Yes, please.
It feels oily because the artemether injection is an emulsion. Little water, plenty oil. Little water, plenty oil. So that would make your artemether injection a water in oil emulsion. It will make your artemether injection a water in oil emulsion. Water in oil emulsion. So for emulsions, you have two types. You have water in oil emulsion, where the water is small and the oil is plenty. And then we have a oil in water emulsion, where the oil is small and the water is plenty. So these are the two types of emulsions we have. One will contain small water with plenty oil. Small water, plenty oil is water in oil emulsion. But if you have small water, what did I say the first time? Let me start afresh. Small water, plenty oil is a water in oil emulsion. Small water mixed together with plenty oil is a water in oil emulsion. But when you have small oil, plenty water, small oil, plenty water, that means you are having an oil in water emulsion. So that is it concerning emulsions. And then you see, ideally, if you are mixing oil together with water, the two of them don't mix together. Always, the oil would rise to the top. But in this situation, we prepare the emulsion in a specific way.
Please, can you go over the emulsion again, please?
Yes, in time. What we do is that the one that is small in volume, the dispersed phase that is small in volume, we put it inside, or we make it into fine droplets. We make them into fine droplets. And when we make them into fine droplets, we add a special ingredient called an emulsifying agent. So what do? We make sure that the smaller portion that is in the form of a droplet is evenly spread throughout the continuous phase. So what do I mean by what I am saying? Let's look at what I'm about to draw. So if you look at this is supposed to signify a bucket or a bowl. and this bowl contains water. This bowl contains water. So I am drawing the water on your screen. I am drawing the water on your screen. So everything here is water. Everything here is water. But the water is the continuous phase. If you want to have an oil and water emulsion, you must make sure that the oil is inside this water in fine droplets. So you will have tiny, tiny, tiny droplets of oil. Tiny, tiny, tiny droplets of oil mixed inside. Tiny, tiny, tiny droplets. The reason why these tiny droplets of oil are not coming together to form a larger, it's not coming together to form one oil component is because we have added an ingredient inside here that is called an emulsifying agent. That emulsifying agent makes sure that the oil is separated inside the water. That will make sure that the oil is separated inside the water. So what I have drawn here, the tiny bubbles would be the oil, and then the huge volume would be the water. So this would be an oil in water emulsion. An oil in water emulsion. But for water in oil emulsion, the water will be small, whilst the oil will be plenty. So these are what we call emulsion. For elixir, we have medications that come in the form of elixir. Elixir, how we prepare elixir is that we get little alcohol and we mix that little alcohol with plenty water. Little alcohol mixed together with plenty water. So an elixir is a hydroalcoholic solution, a mixture of alcohol and water. Is a hydroalcoholic solution of a bitter or nauseous drug intended for oral administration that has been sweetened. So elixir, little alcohol mixed with a large volume of water. And we use elixirs for drugs that are bitter or drugs that will cause somebody to want to vomit. And we also add a sweetener into that liquid preparation. An example is your paracetamol elixir. We usually call paracetamol syrup, but most often the para solutions that we have are elixirs. They are elixirs. So they get little alcohol, mix it together with plenty water, put the medicine inside, and then add a sweetener. So that is what we call an elixir. And most of your the para syrups, if you call them para syrup, most of them are not syrups. They are elixirs. They are elixirs. Even your Piriton is mostly elixir. Your Piriton is mostly made in the form of elixir. So yes, that is elixir. Syrup. We have the tendency of calling every liquid preparation a syrup, but syrups are specific. Some of you are bakers. Some of you know how to bake. And some of you in your baking usually use syrups. How do you prepare your syrup? By getting plenty sugar and mixing that plenty sugar with water. And when you are mixing that plenty sugar with water, the water you're using is small. So all the sugar does not dissolve. So what do? You apply heat. The heat you are applying is going to cause all that sugar that hasn't dissolved to now dissolve in the water. And then when all that sugar dissolves in the water, what you end up forming would be a very thick solution, a very viscous solution. The viscous solution you have now formed, the thick solution you have now formed, is what we call a syrup. The thick solution you have formed is what we call a syrup. So that is how syrups are made. So after forming that syrup, that is when you will now put the actual medicine inside it. That's when you put the actual medicine inside it. So the syrup medications we have are made up of concentrated aqueous solutions of sugar. But nowadays, it's not every instance that we use sugar. There are some instances that instead of using sugar, we use a sugar substitute. We use a sugar substitute, especially for the diabetics. The diabetics can't use sugar because it will make their blood sugar level go high. So we rather use a sugar substitute for them. That is why, if you have noticed, some of the diabetic patients, when they are giving them liquid medications like syrups, they usually give them Zincovit as their multivitamin, because Zincovit is made with sugar substitutes. So it will not cause their blood sugar level to go high. So syrups are concentrated aqueous solutions of sugar or sugar substitutes, and they may or may not add a flavoring agent. And whatever medication they are adding in there must be water soluble. Whatever drug that you are mixing with your syrup must be water soluble. So that is a syrup. Now let's come to tablets. Tablets are solid dosage forms. Tablets are solid. A tablet can be made of one or more active ingredients mixed together with excipients. We've already discussed what excipients are. We also discussed what active pharmaceutical ingredients are in our class earlier. So tablets are made up of one or more pharmaceutical ingredients mixed together with several excipients. Your amoxiclav has two active pharmaceutical ingredients, amoxicillin plus clavulanic acid. Your Gibidol has two pharmaceutical ingredients, your paracetamol and diclofenac. APC has para, aspirin, and caffeine. FPAC has para, aspirin, and caffeine. Your pregnant care tablets have multiple multivitamins in there. So that means it has multiple active pharmaceutical ingredients. So tablets are mixed together with their solid dosage form that consists of one or more active ingredients mixed with several excipients that have been compressed to form a tablet. The issue with tablets sometimes is that they can irritate the stomach. They can irritate the stomach. That is why somebody can take a tablet medicine and complain of stomach discomfort or stomach pain, because the tablets can irritate the stomach. And tablets also have a slow onset of action. Why do they have a slow onset of action? Has any of you, all of you have done it before. You have all put a tablet in water before and watch what happened to the tablet. When you put that tablet in water, what did you see? You realize that after a few seconds, the tablet began to break apart. That breaking apart is what we call disintegration. So you put a tablet in water, it will first disintegrate. After disintegrating, it would dissolve. After dissolving, that is when it will get absorbed. So in your stomach, when you swallow a tablet, the tablet you have swallowed would have to first disintegrate, then it will dissolve, then it will get absorbed. And then next semester we'll discuss first pass effect, but let's deal with this ones for now. So the tablet would disintegrate, it will dissolve before it will get absorbed. All of these processes are time wasting. It takes time. So before all these things will occur, before the drug will start working, a lot of time has passed and your patient would have been dead by then. So in an emergency, we don't use tablets. That's why we rather go with IV or some other form of injection. But we don't use tablet because they have a slow onset of action. It takes time for them to start working because of all the processes they need to undergo before they can start working. So tablets have a slow onset of action. Powders are just like tablets, but the only difference is that for a powder has not been compressed, but a tablet has been compressed. So a tablet can contain one or more active ingredients, but mixed together with several excipients. A powder can contain one or more active ingredients mixed together with excipients. For example, there's a diclofenac powder that people can take orally. I think the brand name is Voltfast. So that is a powder with one active ingredient. You can also have dress powder. Dress powder is mixed together with povidone and metronidazole. That is 2 active ingredients. You can have lexporine powder, which is made up of 3 active ingredients. So you can have powder made up of 1 or several active ingredients mixed together with excipients that have not been compressed. So that is what we call powders. That's what we call powders. And powders are valid dosage forms. We have creams. Creams are elixirs. No, creams are emulsions. Creams are emulsions. But mostly, the creams that we use have more water than oil. Creams have more water than oil, making them oil in water emulsions. Making them oil in water emulsions. Your creams are made for external use. You can either use them on the skin or on mucous membrane. Mucous membrane can include the eye, the nose, the ear, the vagina, the rectum, all of the mouth. All of these are mucous membranes. All of them have mucous membranes. So that is cream. They are meant for external use. They are less greasy, they hold shape, and then they spread readily. Ointments, on the other hand, are very greasy. They are thick and they are semi-solid. There are some ointments you apply on your skin and it will feel smooth. There are some others you apply on your skin and I feel that there's sand inside. Why is there that difference? There are some ointments that contain dissolved drugs inside them. The one with dissolved drugs in them are the ones that will be smooth on the skin. But the one with the dispersed drugs are the ones that will feel like there's sand inside them. The drugs haven't dissolved, they have what? Dispersed. So it means that it will feel gritty against the skin. If you have observed joy ointment is actually Vaseline, petroleum jelly, that they have added a dissolved medicine inside. That is why when you apply joy ointment, it feels smooth. It feels very, very, very smooth. But there are some others, when you apply them on the skin, it will. Sorry about that, my network went off again. Sorry about that. Okay, so let's continue. So that is ointments. That is for ointments. We also have gels. Gels are non-greasy. They are thick, they are semi-solid, and then they are aqueous homogeneous mixtures, meaning that your gels are mostly made up of water. They are mostly made up of water. And because they're mostly made up of water, it is easy for you to wash them off with water. That means if water pours on them, it is easy for the gel to be washed off. It is easy for the gel to be washed off. Capsules. Capsules are solid dosage forms. Capsule is just a container that contains the actual medicine inside it. A capsule is just a container made up of gelatin. It's a container made up of gelatin that would have the actual medication inside it. We have two types of the containers. We have the hard gelatin capsule and we have the soft gelatin capsule. The hard gelatin capsule is to contain the medicines that are made up of powder or that is made up of beads. So they only contain solid medications. A hard gelatin capsule would only contain solid medications. So those made up of powder, those made up of beads. So that means that your amoxicillin capsule is a hard gelatin capsule because it will contain a powder inside. But those multivitamin capsules that contain beads, multicolored beads, those are also hard gelatin capsules because the beads are solid. So hard gelatin capsules are to contain solid medication, while soft gelatin capsules are meant for liquids and semi-solids. So your fish oil, your vitamin E oil capsule, your omega-3, they are mostly soft gelatin capsules. If you open them, you see a liquid inside. There is a reason why we have put the medications inside capsules. That is because there are some medicines that when the stomach comes into contact with them, the acid in the stomach will destroy those medicines. So we use the capsules to protect those medicines. So if Akosia, with all her wisdom, opens up the capsule and pour its content inside her mouth direct, when that drug gets into the stomach's acid would destroy the medicine and render that medication useless. So please leave your capsules alone and swallow them as they are intended to be swallowed. Swallow them as they are intended to be swallowed. Now, finally, the last dosage form we'll discuss is suppository. For suppositories, they are intended to be inserted in the body. The ones we commonly use are the ones we either insert in the rectum or the one we insert in the vagina. The rectum one, we usually call them just suppository, but the one for the vagina, we refer to them as pessaries. Now, your suppository is made up of the actual medication mixed together with a waxy substance. An actual medication mixed together with a waxy substance. You mix it with wax. Now, if you have realized outside the body, the temperature of the room temperature is 25 degrees Celsius. Temperature of your fridge is ranging between 4 to 10 degrees Celsius, but your body is 37 degrees Celsius. So mean that the temperature of the body is usually higher than the temperature that is outside the body. So when you insert your suppository, your high body temperature is going to melt the wax. When the wax gets melted, the medicine would now get absorbed into the bloodstream through the through the walls of through the blood vessels that are lining the walls of your body. So when the medicine gets absorbed into your bloodstream, the waxy substance would not get absorbed. Rather, you would poop out or you would excrete out the waxy substance. That is why, for those of you who have used suppositories, after a while, you feel the urge to use the washroom. And usually what you see is oily. The oil you're seeing is the melted waxy substance. It is the melted waxy substance. So that is it concerning suppositories. So with this, I will bring my presentation to an end and then allow you to ask your question in the next 10 minutes. So please, if you have a question, the floor is open to you to ask. Yes, Lucy, do you have a question?
Sir, please.
Yes.
Yes, sir, please, I have a question.
Lucy, please ask your question.
Please, sir, my question is for the capsules. You said
Wait,
we have the
you have the what?
The lower, the hard, and then the soft one.
Yes.
But part of the capsules that contains the tablet.
No capsule contains a tablet.
Sir, drug like
Is it a caplet?
Doretta. Yes.
Caplets. Okay.
Yes.
Caplet is not really a capsule. It's like a mixture of a capsule and a tablet. It's more like a tablet that has been made in the form of a capsule.
Okay.
Yes, it's like a tablet that has been made in the form of a capsule, but it is not a capsule.
Okay, thank you.
You're welcome. Mary, please ask your question. Mary Asante, you have a question?
Yes, sir.
Please ask.
Sir, can you please explain further about the oil in water solution and emulsion and the water in oil emulsion? I'm finding it
Like
confusing.
saying oil in water means that the oil is inside the water.
Okay.
So that means that the oil will be small in volume, whilst the water will be what? Plenty.
Plenty. Okay.
Water in oil emulsion means that the water is inside the oil. So the water would be small, whilst the oil would be plenty. That is all it means.
Thank you.
Then we have used an ingredient called emulsifying agents to make sure that the oil and the water do not separate. That is it about emulsions.
Emulsify agents.
Joycelyn, you have a question?
For sure.
Joycelyn, do you have a question? No, Joycelyn doesn't have a question. If Joycelyn doesn't have a question, Florence, please ask your question.
Yes. Please, I did not get the reading assignment. Could you please repeat for me?
I said go and find out the physiological effect of all those drugs I have listed. Find out their physiological effect. Those are classifications based on physiological effects. So go and find out what work those drugs do, those classifications of drugs do. So that's the assignment.
Okay, thank you.
Good. Florence, what's your question? Florence Dansoa, what's your question?
Sir, please, I just asked. I asked about the assignment.
Okay. Thank you. Dorcas, what's your question?
My question is, drugs like suppositories like clotrimazole pessary. You know, it's like a tablet. It's hard in nature, in solid.
Yes.
But yet we call it suppository, and then we insert it into the vagina. Are they still pessaries or they are tablets?
They are tablets. That's why if you read the if you read the package, they will say vaginal tablets. So they are tablets. Suppositories and then the pessaries are made up of wax. They are waxy substances with the medicine mixed together in there. But your vaginal tablet is a tablet. The only difference is that the vaginal tablet, it can easily be applied in the vagina. It has been formulated for vaginal use. But your pessary is made up of wax. Yes. So
thank you.
There's a difference between the two. I hope you are good. Dora, what's your question?
The assignment, I was not able to write it.
You don't have to write. It's on your slide. I have given you this list of classes of medicine based on their physiological effects. So go and find out what their physiological effects are. So analgesics, what do they do? Antacids, what do they do? Antibiotics, what do they do? Antidiarrheal agents, what do they do? That's the question I'm asking. Okay.
Sir, please.
Mhm.
I didn't get the difference.
Yes, yeah, ask your question.
Yes, sir. Under the emotion, I
Mhm.
didn't get the difference between the dispersed and the continuous phase.
You didn't understand the dispersed and the continuous phase.
Yes, sir.
The dispersed phase is the one whose amount of volume is smaller, whilst the continuous phase is the one whose volume is larger. That's the difference. So the one that is smaller in volume, we call that one the dispersed phase because it is dispersed inside the one with the larger volume. The one with the larger volume is what we call the continuous phase. That's it.
Thank you, sir.
You're welcome. Essay, you have a question? Hanif. If she doesn't have a question, Francisca, do you have a question?
Yes, sir. Please, you talked about excipients. I didn't get that one. Can you go over for me?
Excipients are the additional ingredients you add to a dosage form that is not the active pharmaceutical ingredient. So you have your pharmaceutical, your paracetamol, 500 milligram. Any other thing you are adding to that pure para to make the tablet is an excipient. You have your Jibidol, 500 milligram para, 50 milligram diclofenac. Any other thing you are adding to those pure medications are excipients. Are you okay?
Yes, sir. Thank you.
You're welcome. Is there any other question? No. Good. Okay. So with this, I think we can bring our class to an end. A gift to your Henny. Do you have a question? No, she has run away.
Yes, sir.
Okay. What's your question?
Sir, please. So if the water, like in the under the emulsion, if the water is small and the oil is small, so how will you say it? Is it what
If the water
oil?
is what?
The water is small and the oil is small. How will
Both
you
of them
say
are
it?
small.
No, the water is small and the oil is small.
Okay.
How will you say it? Is it
Water is
oil?
more, and then the water, and then the
Oil.
oil is small.
Yes.
Okay. Then to be oil in water because the oil will be inside the plenty water.
Okay.
So oil in water emulsion.
Okay. Thank you, sir.
You're welcome. Francisca, do you have another question? No.
I have a question.
Joyce, do you have another question?
Doris. Yes.
Please ask your question.
Sir, can you get the slide?
Huh? What's your question?
The slide?
Please, I have circulated the slides earlier in the week. So you should have it by now. If you don't have it, please contact your rep. Contact your rep.
Sir, please, I have a question.
Sir, please, the slides are in the group. They have it.
Okay, so my question is, during the drug development, we learn in the second phase that the medicine is being tested on healthy persons to find efficacy or toxicity. So I was asking whether during the COVID time, were they using us as an analysis or?
You see, the thing about the COVID situation is that when the COVID came, the company that made the vaccine were already testing. They had made a similar vaccine and they were already doing the testing for that vaccine on people. But then when the COVID came, what they did is that they did a slight change in the drug. But then because of how the COVID was killing people, they didn't have time to do all the all the long processes of the of the clinical trials. So they expedited certain things for them so that the medicine can come out early. But then they had already started doing something before the COVID hit. So when the COVID hit, we were just lucky that somebody was working on it already. So they just expedited certain protocols for them so that the vaccine can come out on time to be able to save lives. So that's
Okay.
Yeah.
Okay, thank you.
You're welcome. You're welcome. Okay,
Please,
so with
I have a
this,
question.
hey, man, we have 5 minutes to your next class, but ask your question.
Please, I was working for a private hospital. We were serving some supplement, which was a capsules. But according to the doctor, it works faster when we dissolve it in any solvent, any liquid, whether it's a soup, a water, or whatever. So I'm trying to contemplate it. Is it true? Because as you explained, some of the drugs, the reason why they are in their shelves is because they react when it gets to our stomach. The acid reacts with them. So are they different from the supplements? Or
No,
he was like,
it still applies to the supplements. It will still apply to the supplements. So you dissolving it in water would also affect how it would work, because if the aim is to protect it from the acid in the stomach and you pour it inside the water, it is going to meet the acid in the stomach and the stomach will destroy it. So I think it might be safer to administer it wholly, but I don't know what the prescriber was, what his aim was. Maybe the patient has a particular circumstance that he wanted to, circumvent by giving the already dissolved capsule to the patient. I don't know exactly what the prescriber was trying to achieve, but ideally, leave the capsules in their shelf when administering.
Hello,
Are you
sir.
okay? Yes.
yes, sir.
Hello, sir.
Yes.
Hello. Please,
Yes.
when are you taking the assignment?
I'm not taking it. It's for you to read. I will take it from you when I'm quizzing you.
We should read on it. Okay.
Read. Good. So with this, I'll bring our class to an end so that we can go and prepare for other class.
Okay, thank you
I hope you enjoyed this morning's lecture. I hope it has been insightful. Good.
Yes, sir.
Thank you. So we would meet again tomorrow for research.
Okay.
Bye-bye.
Bye.
Bye.